Welcome to the Vax Up podcast, a podcast that shines light on health organizations who use social technologies to get accurate vaccine information to their communities. This show is brought to you by the Bay Area Global Health Alliance and the Sabin Vaccine Institute, both members of the Alliance for Advancing Health Online. Vax Up is produced by the team behind A Shot in the Arm podcast. And now here's our host, global health strategist and advocate, Ben Plumley.
And let me add my welcome to this episode of the Vax Up podcast, where we are profiling interesting collaborations to promote vaccine confidence through the use of digital media and social networking platforms. In this episode, we are flying up to the 38,000-foot level to look at a selection of the Vaccine Confident Fund's grants, some that we've covered in previous podcasts, and one that we've just got hot off the press results on, as well as other approaches that our panelists have taken to engage hardly reached communities. All of this to ask the question, can these tools build trust in healthcare systems amongst those communities hardest to reach? Without doubt, there are ramifications and opportunities for public health outreach strategies outside of vaccine confidence, as well as in other communities and in other settings. But before introducing our panel today, I first want to recognize that Sacramento, where I'm recording from, is the ancestral homeland of the Nisenan, Maidu, Miwok, and Mewuk peoples, who are the indigenous peoples of this land. Our first guest, then, is Trevor Stratton, Canadian First Nation and international Indigenous health advocate and community leader. Trevor is from the Mississaugas of the Credit First Nation, Canada. He's widely known in global health circles as a passionate and effective advocate for the rights of Indigenous communities, particularly in infectious disease. He's a nationally respected leader in Canada's First Nation communities as they address the wrongs and the challenges they face with health authorities, only made more visible by COVID. And he is in the process of building a new home from scratch. Trevor, how are you doing?
I'm doing well. A little tired with all the heavy workload. I'm sure you know what I'm talking about, but thanks for inviting me.
Well, it's great to have you here. I know it's been taken a while to get you on the show again, and loving the concrete foundations that you've been able to install in your new home. We're also joined by Nadia Diamond-Smith, Associate Professor in the Epidemiology and Biostatistics Department and Institute for Global Health Sciences at the University of California, San Francisco. Her expertise is in maternal and reproductive health in the developing world, with a focus on gender inequality, women's empowerment, family planning, abortion, nutrition, and pregnancy. She's a public health demographer, and she joined us in an earlier Vax Up podcast to talk about her collaboration with the Maya Health Alliance. Nadia, it's great to have you back. I'm glad we didn't scare you off. How are you today?
I'm doing great. It's wonderful to be back. Thanks, Ben.
And rounding out today's panel is friend of A Shot in the Arm podcast, our sister podcast, Georgia Arnold. Georgia is the Senior Vice President of Social Responsibility at Paramount, and she's the Executive Director of the MTV Staying Alive Foundation, which produces MTV Sugar across Southern, East, and West Africa, as well as India. Georgia, welcome to Vax Up.
Oh, it's great to be here with you, Ben. I love doing these with you.
Now, as I was looking at your resume, I see that you are also head of VIS Social Impact. What on earth does that mean?
Well, for Paramount, I produce a lot of the social impact content. So it can be scripted or unscripted, documentary series, anything that covers climate equity or health. And I think most importantly, we have to ensure that we're creating impact at the back of it. So it's not just about a water cooler moment with the documentary series. It's about what are we doing with our audience to carry them along once they understand the messaging. How can they understand their choices or take part in activations and stuff like that.
Now, for our Vax Up audience that may not be so familiar with MTV Sugar, could you give us the brief elevator pitch?
MTV Sugar has been going for 12 years now. It's a mass media campaign, and we placed them in different countries. So in Kenya, South Africa, Nigeria, Cote d'Ivoire, and India, where it's called MTV Nished, which means taboo. And we use all platforms to reach young people, to give them information about their sexual reproductive health and rights, also about TB, mental health, and most recently, of course, we got involved with COVID as well. And for us, with all the innovations around healthcare, it's about giving young people the choices that are available to them so they can make their own decisions.
Well, let's get right into it, shall we? The challenges of building confidence, vaccine confidence in hard-to-reach communities. So the Vaccine Confidence Fund has funded projects over the last year to look at those challenges and look at the solutions that digital and social technologies can have as communities and the healthcare providers that serve them, particularly vaccine implementers, build confidence in vaccines. And there are two projects that have stood out to us here at VaxUp. The collaboration that Nadia has been involved in between Maya Health, UCSF and Stanford University, reaching Indigenous rural women in Guatemala, and a collaboration between the Star Blanket Cree Nation and the University of Saskatchewan's Morning Star Lodge, a research institute designed to work specifically with First Nation and Indigenous communities. Now, these are projects that are important in their own right, but they serve as a useful entry point to broader efforts to engage these hardly reached communities. So, Trevor, if I may start with you, Indigenous vaccine hesitancy is not just limited to COVID-19, is it? A major issue right up front is that the public health community does not have an adequate understanding of the challenges First Peoples face. Indeed, even in recent history, it's a relationship that's been hostile, controversial. Could you share some of the context and historical background about why there is such distrust in medical authorities in the communities that you serve?
Well, I think it's not just medical authorities there's mistrust of, but it's authority in general, or any kind of a system or governance that isn't Indigenous, because our ways are a lot different than what we call settlers. And many of our communities are remote or even isolated, meaning like fly-in communities. Even young women who have never left their community before, when they want to have a baby, they have to fly out to do that, or to go see a dentist or things like that. So there's that issue. But there's been, over hundreds of years, there's been a lot of different people and groups and governments knocking on the door, scratching on the teepee, whatever you want to call it, with this thing saying, here's a book. This has all the answers. Just take this book and everything will be fine. But the book wasn't written by us or for us, these systems that come our way. And the messaging that's made, the public health messaging is made by and for settlers as well. And it doesn't resonate with Indigenous people. In my experience and what I know from my friends, family, and community, is that a lot of Indigenous people look for information from trusted friends and family and relatives. And if it comes from them, they'll believe it. But if it comes from someone they don't know in a white lab jacket, there's still a lot of that mistrust. But it's also a lot of misinformation can be passed this way. So if our community members have the factual information, it's not gossip. It's actually whispering into your friend's ear. This is the truth. This is the fact, and that's what we pass to our friends and family instead of perhaps misinformation. Our infrastructure in communities is very often not very well developed. Resources are quite scarce. There's housing shortages, overcrowding in houses. Sometimes families are sleeping in shifts because there just isn't enough room. There's a lot of turnover in our workforce as well. And many of our communities are very, very small. So the role of a community health representative, a CHR, which most of our communities have, they're different. This description of their job is different in each community. So one can be, as high up as a registered nurse or that. And in another community, the CHR might be, her health background might be that she's been to 3 or 4 health conferences. There's boil water alerts because our groundwater is poisoned in many of our communities here. There's no sidewalks, people getting run over, and some communities are just connected by footpaths. That's how underdeveloped or no roads in these isolated communities. That's some of the issues without going too deep into it.
Nadia, I wonder, listening to Trevor, how do the challenges that he's just articulate resonate with you in the work that you and the Maya Health Alliance addressed in Guatemala?
Yeah, thanks. Yeah, a lot of those issues really resonate with what my colleagues at the Maya Health Alliance and Stanford and I found in our work. The way information had been crafted and developed, often didn't resonate with the communities we were working in. And one of the things that we really ended up finding and highlighting in our work was the importance of language. In the rural Mayan communities, there's many different languages that are spoken. And so often the content that was delivered to these communities was in Spanish, which many people didn't speak. And so something as simple as just being able to create information in the language that people were more familiar with, we found seemed to be very important to people for their trust, but also actually was able to lead to them, having more information and being able to act on those health behaviors.
And as a researcher yourself, Nadia, hearing what Trevor said about the sometimes difficult relationship with researchers, how have you in your work, both with the Maya Health Alliance, but also in India, how have you sought to address that?
Yeah, it's definitely a hard question, but something I do feel like the global public health community is thinking more about and talking more about. And I'm very heartened to hear students pushing for that and senior faculty starting to integrate that into how they're designing their research and how they're working with partners. I think one thing that I've always focused on, and I think a lot of my colleagues do, is building partnerships from the beginning with, not just researchers in the different contexts that we're working, but also local community partners, so that, I think people talk a lot about community engaged research, but so it's not just once you get there, you have a community advisory board and talk to them, but it's a few steps back when you're first figuring out, like, what do we need to work on? What does the community want? What are the important topics? I might think something's really important, from my, California office, but that might not be what really resonates with the needs of a certain population. So I feel I've been really heartened and excited to see how many people are building partnerships over many, many years with local community groups and organizations so that they can then direct their research towards meeting those needs. But it's a hard thing to do. COVID made it harder in many ways when we're, stuck in our office or in our homes. But I think I really believe that the times are changing, but it's a hard relationship, and one that requires a lot of time and commitment and energy on both sides.
And Georgia, if we look at the work that you and your teams have done in Nigeria, South Africa, Kenya, and India, one of the primary reasons for you doing MTV Sugar is precisely because these young folk don't trust or have concerns about their interactions with the health authorities. So how do you respond to what you've heard from Nadia and Trevor? How does it resonate with you?
I think, well, first of all, it's so interesting hearing both of you speak. And I think for us, it really resonates because what we hear from our audience time and time again is that even if they know what they want, even if they know where to go, so often they turn up at a clinic and they're laughed at by a nurse, or they are dismissed by a nurse because they're too young, they're not married, they're not given the access to actually what we're empowering them to ask for. And it's a real challenge. And I think, for us, what we're really looking to do is make sure that we work both with the young people where we really want to shift social norms with, but also we know that increasingly we have to work with the norm holders as well in order to make sure that we can, it's all very well giving a young person choices and options, but if you're not changing the norm holders' perspective, then how are you're never really going to change anything, not in the long term. You're not going to reach that tipping point.
Now, Nadia just touched on something as well, Georgia, that really strikes me, that COVID-19 changed everything. We were in our homes, we weren't able to be out in the communities. And I guess I just wonder, it's a question for all of you, I guess. How has COVID-19 transformed the approaches that you've taken to interacting with communities? And Trevor, maybe I could kick off with you first.
Yeah, that's a really good question, because there's around 600 First Nations communities in Canada. There's many Inuit hamlets and Métis settlements. But there was a study, an international study that was done by Indigenous researchers on HIV in New Zealand, Australia, and Canada. And it showed that high mistrust in healthcare services. But for the most part, here, most Indigenous community leaders implemented social restrictions. And in many cases, those restrictions were more stricter than provincial guidance from health authorities, and with roadblocks in and out of the community and things like that. Most of our communities did distribute vaccine shots themselves, but of course there was also quite a bit of resistance by our Indigenous citizens. They don't necessarily agree with the leadership. Lots of conspiracy theories are in circulation. What's in it? Microchips, cells from human fetuses, and I know someone that's died from vaccinations. I don't know how many times I heard that. I don't know how that's possible, since it's such a small statistical note, But as COVID dragged on, a lot of people got tired of it. They got that fatigue, and people got lonely and started to gather. And we started to get deaths and denials that COVID exists, even when they're dying in the hospital. But a lot of our communities, they were going door to door with deliveries of groceries and other different supplies and fun games and things to do for children, with medications and information and that kind of stuff, which helped to keep that vital connection. But some communities had very high infection and death rates, while others were rather low. But they were started to do Zooms, and everybody pivoted. When many of our communities had no experience in this, and now we're experts. So,
Right, aren't we? We look absolutely fantastic and professional up top. Underneath, it's a completely different question. But Georgia, I want to come on later to some of the work that MTV Sugar did using social and digital media. But, what you were doing prior to COVID was producing soap operas, essentially, that needed people out in the community, film crews, actors. That presumably came to a sudden stop with COVID. And you're on mute.
Sorry. So you did say you want to come back to how we responded to COVID. So I might now be answering the question you want to ask me. But I think for us, it was transformational from day one, because what we realized is we could not be business as usual. We couldn't have a crew of 50 people with actors and makeup artists and whoever. But we also realized pretty much overnight, once global lockdown happened, that what we are a behavioral and information campaign. And so that we had to make sure that we could produce content that we could get out as quickly as possible. So we came up with a series called MTV Sugar Alone Together. And MTV Sugar Alone Together is 6 countries. So we had actors from Botswana, Kenya, Nigeria, South Africa, where am I missing? Cote d'Ivoire and the US. All of our actors were in lockdown. We produced 70 10-minute episodes from April through to end of August 2020. And we scripted them in blocks of 10, because what was really interesting was everything was changing so quickly. The lockdown rules for each country was changing on a weekly basis. So we had to make sure that we were staying up to date with the messaging. Now, my team aren't experts on COVID. So we work with the London School of Hygiene and Tropical Medicine, to review our scripts to make sure that as far as anyone knew, our messages were correct. And B, also they did an evaluation in terms of what young people thought about COVID, what they'd learned from the series. And every night on YouTube, we premiered the episode, and we had some of our actors talking to our audience, and the audience were talking to each other. what we saw was really interesting, because we saw at the sort of early stages, people were very scared in terms of all of the messages that were coming out. But when someone for the first time a couple of weeks in said that their aunt had died of COVID, we saw the community that we were building, because we had an audience from really across Africa, I would say, and they were supporting each other. And they were then reflecting on their own experiences. And they were then talking about, we had someone who was HIV positive talking about the fact they couldn't get to their clinic because they couldn't go on public transport. So how did they get their HIV medication? And it was fascinating and heartwarming to see the community that we built up. And we do know that from the London School evaluation, we know that at least of the young people who'd watched it, almost all of them described it as entertaining, realistic, informative, and memorable. And entertaining, 91% described it as entertaining. For me, that's crucial, because if we're not being entertaining, no one's going to tune in tomorrow. So I think that's really important. And more than 90% said that they'd learn new facts about how COVID spreads, about what the symptoms are, how they can protect themselves, and crucially, where they can go for more information. So I think it was transformative for us. We have really adapted this work in terms of making sure, although we've gone back to making the big TV productions as well, because there's still a space for it, but we can also be much more rapid in the way that we work, and we use digital much more. And one more thing I'll add is the other thing that it changed was our peer education within communities, because we have an amazing learning course with MTV Sugar that we take across countries, but we couldn't do that face to face. So then we turned to Facebook. And that was amazing, being able to still use those contents, still have our peer educators, and reach out to young people in a way, as you said, Trevor, we all had to do it. It's not ideal, it's not perfect, it's not as good as face-to-face, but under the circumstances, it meant that we could still talk about the important things.
Well, which gets us into addressing some of the solutions, because these challenges are the mother of invention. And I think, Nadia, one of the things that so gripped me about the collaboration that you at UCSF, Stanford had with the Maya Health Alliance was that you took these very simple animations and then you adapted them to fit the needs of girls and women in rural Guatemala and Indigenous communities. Can you tell us the process of how all that came together?
Sure. Yeah, it's really been a fun and interesting partnership, and it's been so great. We're trying to do more work together, and none of us have ever met in person still. So it's been quite the COVID love story. But yeah, I mean, so we, went through a formative design phase, talking to community members about some of the challenges they were facing, and then, as you were saying, Ben, adapted some of the content that the digital medic team at Stanford had been using previously to that, to the rural communities in Guatemala. And that was a very iterative process, showing them the videos. Like, does this belt look right? Does this, color, was this representative of, what someone would wear in these communities? And also the language, we did it in 3 different Indigenous languages, although there's many more. And very careful choices and discussions about what word was the appropriate word and would resonate and mean what, we were hoping to convey. And, it was interesting to me and surprising. It wouldn't have been what I would have expected the content to end up looking like. It was kind of cartoons. It wasn't as like realistic people as would have been my assumption people would have liked, but it really seems like it reflected what the community members, thought would be the most trustworthy and help them understand the content the most. It was really exciting and interesting design process with really great findings. So that's even more fun.
One of the things we weren't able to get into in the last podcast with you was your work in India. And I'd love to know, just how you and colleagues have collaborated with young women's groups in the subcontinent to address vaccine confidence. And I know this will be really striking for Georgia, given the work of MTV Nished. But can you tell us a bit about what you've been doing in India?
Yeah, so I was fortunate to have a separate grant with the Vaccine Confidence Fund with some colleagues in India when we'd been working together for the previous few years on work with postpartum women and pregnant women. And really it came to light that during the COVID pandemic, even though the vaccine had been approved for pregnant and breastfeeding women, uptake was extremely low in that population. And India has a different set of norms, and especially gender norms, and issues with women having limited mobility and lack of decision-making power. And we had some amazing community partners. This is in northern India, a local doctor who had over the past years developed WhatsApp groups that had hundreds and hundreds of pregnant and then breastfeeding women, and he would sort of answer their questions. And so after, again, a formative phase with women in this setting, we ended up deciding to try developing a chat bot, which we would deploy over these WhatsApp groups. So again, we were leveraging systems that were already in place that had been, were working in the communities as a way for him to provide information about, infants and, pregnancy and such. And it was very interesting, very different set of factors that were sort of.
And isn't this, we lost you for a second, sorry.
I was just going to say there's a different set of factors that were the main barriers as opposed to our Guatemala study, which touched on many of the things Trevor brought up about mistrust in the government and, myths and misperceptions about what was in the vaccine. In the Indian context, the women that we were working with, they all wanted to get vaccinated. And a lot of them said they'd gone and tried to, but instead were facing barriers. I think this touches on a little bit of what Georgia was talking about, where they went to the health facility and the providers said that they weren't eligible, even though, they Googled it, they knew that they were actually eligible. So it's a completely different set of factors, which led us to have to create different content, which actually we tried to address within the chatbot, some tips and tricks for talking to your family, negotiate, maybe being able to get the vaccine if you wanted to, different approaches that they could use, and similar to addressing potential barriers they might face with health providers. So it was really fascinating to see the different challenges faced by different communities.
I wonder, Georgia, have you used chatbots? I know that a partner of all of ours who's been on the VaxUp podcast, Shujaz, is using those in East Africa, in Tanzania and Uganda. But how have chatbots been adopted by MTV Sugar more broadly?
So we've been using them in India with MTV Nished, and I would say to mixed effect. What we know is that when there is a human being at the end of the conversation, then that young person is going to be more engaged with the human. And what we've seen with our work in India is we can get people to go onto the chatbot, but what we are struggling with at the moment, and if you have any advice, Nadia, it's definitely hugely appreciated and needed, quite frankly, because we're not seeing them go through the system. Now, I think partly is because chatbots, we all know what they do, we all know how they work, but they still are very in their infancy. There is still so much development to come. And so for us, I think we still want to use them, but we are really aware that there is limits to them at the moment. And we want to see how we can work with the chatbot providers. So we work with different chatbot companies to see how we can develop them further. But that's what we all do, right? We learn, and the best way to learn is actually when it's not successful in the first place, because that makes us try it again and again and do better.
I can just jump in here. I can jump in. Yes, we've had a lot of discussions as a team also about, I think the women seem to like them, but we didn't actually end up seeing an impact on vaccine uptake. So, I think that we as a team have been thinking about, what was missing, or, is this the best tool? And also, I think that this was a very specific setting where we were using a platform that was already an established, trusted, these big WhatsApp groups led by a doctor that women had been part of for a long time. And, we've wondered if these were, deployed in a broader, over Facebook or something like that. We have some questions about whether people would engage in the same way that they did in this already trusted group. So, I definitely would agree that there's a lot we need more work that needs to be done on really making them engaging and valuable, and how much of an impact they can have. So,
yeah.
And involving real people. And Trevor, I suppose this is not about throwing the baby out with the bathwater, embracing the shiny new technologies. It's really about the intertwining of what we know works, traditional approaches that work, and harnessing these new tools to help us reach people more effectively. One of the things that I found so fascinating with some of the First Nation initiatives to promote vaccine confidence, and I know this is something you've been a part of, is the way in which traditional practices and modes of engagement have been utilized. And here's an example. Morning Star Lodge and the first, the Star Blanket Cree Nation worked with community elders, the tribal leaders, to get them to sort of pray over the vaccines before they were distributed. And this wasn't so much a case of seeking to directly address vaccine misinformation, but rather that this is part of the fabric of the way the society lives. And I just wonder, have you seen this in other settings, and how valuable is it?
Ben, I don't know if people know this, but our traditions, Indigenous traditions, were actually illegal. Sweat lodges and potlatch ceremonies. We weren't allowed to speak our languages. We were taken from our traditional livelihoods on the land and put onto postage stamp communities and provided with, rotten flour and nasty old, grease to fry it up. But so we've been, purposely separated from our culture through like settler humanitarianism approach here. And everything, anytime we get together, anytime we communicate around health messaging, we need to get back to our culture, because that is healing for us. There's this disconnection. There's so much racism, and we've been considered lower on the, social strata for so many years, that embracing our culture and understanding who we are and connecting with our ancestors is part of our social determinants of Indigenous health. That's why it's intertwined like that. And each community does it a little bit differently. Even at our, I work in HIV. I've been living with HIV for 32 years. We just had our 9th International Indigenous pre-conference on HIV and AIDS before the big international conference. And we do the same. We open with prayers. We bless the food. We call the ancestors in at the beginning and thank them at the end and let them go back to the spirit world. We have smudging ceremonies. We have, everything is a ceremony. Research is a ceremony. And it has to be. This is our health. It's implementing intervention on top of interventions. It all has to be one. You know what I mean? It has to be one good package, not just COVID talk, but all of it. All of our global health, all of our relations, even our grandfather rocks have spirits. You know what I mean? We honor all of that. And that's incredibly important to us, to our health and well-being.
Yeah, I got to say, on a personal note, I'm quite envious, because when I look at my ancestors, more recent ancestors, it's more sort of, oh my God, really? But
I've got some of those ancestors too, Ben. I've got a lot of blood in me, yeah.
but this sort of gets us into the impact side of the conversation, and Trevor, again, just to stick with you for a second, there was one thing that really stood out to me with the Star Blanket Cree Nation work. They tested out 2 interventions on their Facebook page. One was essentially reposting messages that they got from established public health communities. Absolutely solid, absolutely, first rate, and couldn't complain about the accuracy. And then they also tested out messaging that the community itself had produced, which perhaps was not as detailed and hadn't gone through the same kind of rigorous evaluation. But what they found was that the community, I suppose this is to be expected, really resonated more with community-generated hosts and interventions, and that really, notwithstanding the vaccine hesitancy that they, and presumably many of us feel, they were able to reach people and get to really concrete behavior change. And so my question for you, I think, is, how have you really blended the traditional with new approaches, new technologies, and new thinking to reach people in ways that perhaps in the last 15 to 20 years we haven't been able to do?
I think that's a really important question. And it's, some Indigenous people will say, we don't need anything from the Western world at all. We need to go back 500-600 years. But that doesn't acknowledge the fact that Indigenous people were evolving all along. And we would have evolved for this 500 years in our own way anyway. We wouldn't be the same. That's one thing that I think is important. But also, the way that Indigenous people use the colonizers' language is different than the way that that the mainstream, native speakers from Europe would speak English or French or Spanish. So, like, for example, in research, we use the word key informant in the Western world. And to Indigenous peoples, that means somebody who's going to rat you out to the cops. Do you know what I mean? It's just that's the way that word is used. So it's not just about, of course, it's important to use Indigenous languages, but it's also about the way we use the colonizers' languages too. But really getting back to we need to find that balance. We need to use Indigenous ways of knowing and doing and being, but we also take the best of the Western world and we use both. And there's been a Mi'kmaq elder here in Canada from the Atlantic coast who calls it two-eyed seeing. And to keep both eyes open so you walk with one foot in both worlds, because some of the science was generated by Indigenous people anyway. Do you know what I mean? Like, Indigenous people are scientists, doctors, and lawyers too. So and we are part of the world. We're not an island. We are part of this world. And I can tell you this, Indigenous peoples have a lot to offer the world. It's not just Indigenous people saying, oh, poor us, come and help us. We have a lot to offer. Now people are looking at global management and these pandemics, and they're going, maybe they were right. Maybe we need to do a better job of global management. Maybe we should take care of this mother of ours.
Do you know, I'm listening to you, Trevor, and it sort of takes me back to something that MTV Sugar did. And that was, I think, quite bravely inviting the London School of Hygiene and Tropical Medicine, indeed the World Bank and the Gates Foundation, in to evaluate MTV Sugar. And this was also a clash of cultures, a clash of civilizations. And I wonder, Georgia, did you approach this with both eyes open? How did you reconcile this?
That's a good question, Ben. And I probably didn't have both eyes open, because I describe it as researchers speak a very different language to the language that I speak. But we also know it's really important. It's really important for our funders to understand whether they're investing in projects that have impact. But it's really important for us to be able to have both a feedback loop that we can tap into at any time to be able to change our messaging if they're not working, or emphasize messaging, but also to be able to track the work that we do. So we've been evaluated by the World Bank's DIME team, by the London School, by Tulane University, amongst others. They've all done very different evaluations over 12 years. And my frustration is that I didn't really understand 12 years ago. I didn't perhaps think we would still be going 12 years later with MTV Sugar. And I wish that we'd been able to say, right, let's do a 10-year longitudinal survey. But what's interesting is that every evaluation that's been done has been different. So we've had longitudinal, we've had an RCT, we've done biomarkers, we've done qualitative stuff. And what we see time and again is that if you've been exposed to MTV Sugar, you're twice as likely to get tested for HIV. We know also that you're twice as likely to know about self-testing. for HIV. And when with the biomarkers, we did it for chlamydia over an eight-month period, and we saw that young women who'd watched MTV Sugar were 55% less likely to have chlamydia than those who hadn't watched MTV Sugar. Now, I can't get into the whys and the wherefores because that's the different language, but for me, it has become invaluable to everything we do. And we now won't start a project unless we have an evaluation partner on board. It's opened my eyes up. It's a whole new world for me.
I wonder, Nadia, how you react to this. Again, I think going back to the collaboration you had with the Maya Health Alliance, you were able to forge a very open, confident, and comfortable relationship with the Alliance over monitoring and evaluation. And I guess, how do you see the 21st century role of the researcher as partner, as Trevor said, as part of the ceremony?
Yeah, I mean, I think it comes back to some of the things I was touching on earlier about it being a collaboration, maybe from the beginning, right? I don't think anyone felt like someone was, I mean, of course, from a scientific perspective, you want the evaluator to be unbiased, but I also, think in this case, we were all part of a team and very committed together to developing something that we felt was both reflective of the needs of the community, but also would make an impact, and that, and we wanted to know if that was the case, and everybody, the local partners and everybody involved, wanted to know the answer to that. I mean, I think getting back to one of your earlier questions, sort of about how COVID has changed things, and thinking specifically about social media type interventions, one thing that I worked a little bit in this space pre-COVID, and I think, there's a lot of skepticism in the scientific community, like, oh gosh, you can't really measure it. Like, what's the population? Like, what do you spread? And I think a lot of what had been done to evaluate specifically social media type of campaigns, had been just like asking people if they saw it, or if they liked it, or if they thought it impacted their behaviors. And what's been really exciting to me is seeing that there's been this shift in people really trying to think through, like, how can these interventions are important, and we can measure them in like very rigorous ways. I'm actually collecting data from people, not just online, or from facilities, or actually looking at like health outcomes or health behaviors. And it's really exciting to see this like shift and like open people. I think scientists are opening their minds a little bit to like, okay, it's not our standard study design where we make this sampling frame and we select, we have to think outside the box a little bit, but it's been really exciting to see how many people are thinking of really innovative ways to measure the impact of so much exciting work that's happening out there in like various social media.
And I think one of the fun things about the Vaccine Confidence Fund is that it has captured a lot of the flowering of creativity. Now we're coming up to the top of the hour, and I know, Georgia, we are interfering, I guess, with a family tradition for you, which is in the UK to get to dinner on a Friday night.
My dad's just gone.
Checking his watch, saying, Georgia, hurry up. So look, last question for you all. Where do we go from here? I mean, from my mind, this has been a fascinating conversation with people from very different worlds coming together and sharing views. And to my mind, there's a lot of commonality. But where do you see this going? Georgia, perhaps I could start with you.
Do you know what I've been thinking about is the digital health world is so incredible, and the innovations that are happening, way beyond my brain in terms of really understanding where we'll be even in 5 years' time. But there is a digital there's something out there that I wanted to bring up in this conversation, because it's almost so simple that it's almost going back to basics. Now, this takes us to Norway and Scandinavia, which is not my normal place of work, but there is a woman who's called Helsesster, who I probably have totally mispronounced that, so I apologize for my Norwegian, but it translates to health sister. And she's a nurse who was working in high schools in Norway. But her frustration was, although she was doing things face to face, she wasn't reaching enough people. So what did she do? She went digital. She created a Snapchat account called Helsesster, and she has become Norway and Scandinavia's personal nurse online. So young people can ask her any questions related to sex for the first time, how does the pill work, handling different difficult emotions, and she just replies on Snapchat. And I love that because it's very, very simple, but it is a real person at the end of it. So it's combining the both. And for me, I think that as we bring digital into our world, and we have to, and it's amazing, it's brilliant, but we mustn't forget the real person as well, both in terms of the need of the client, but also who's talking to them at the other end.
Nadia, your thoughts?
I love that. I hadn't heard about that. I'll have to look it up. Yeah, I mean, I would say, to me, what's exciting and looking forward is that, I think we know technology and access, especially bringing it back to sort of thinking about rural communities or hard to reach populations, or especially women and girls. I think that as we move forward, and I think I see that people are finally stopping to be like, oh, well, still so many people don't have access or don't have phones, but really the realization that times are changing really quickly, and like more and more really Indigenous communities are able to access information through these various approaches, or women who might not have as much power in the household actually can be connected in various ways. So I really am excited and to see that we can use these tools and they can reach the populations that I think there's sort of in this idea are still unreachable by some of these approaches.
Thank you. And Trevor, last words go to you. What's the way forward, do you think?
Well, for Indigenous peoples, I don't, and when we're speaking on a global level, we need to talk about the United Nations Declaration on the Rights of Indigenous People, and the fact that consultation is really important. It's important to get the free, prior, and informed consent of Indigenous peoples, and I'll also understand that in addition to human rights, we have collective rights where you need to go to the Indigenous authorities first, ask permission to work in the community, and then go to each individual and ask for their consent. So there's lots of recommendations in that UN DRIP document. But in Canada, we have the Truth and Reconciliation Commission, which did a great big investigation, and there's 94 calls to action there. So it's really important. There's stuff already there for Indigenous that we can implement. It talks about, equitable partnerships and nothing about us without us. But I really like how Georgia talked about that, the person-centered approach, working with each individual. We were checking on people, knocking on their doors. Are you okay? Has anybody seen Trevor, And Nadia was talking about talking about access. And access, we realized in many of our organizations and communities realized that access was incredibly important. And many reached out for funding. There's lots of funding was released, at least in this country, for dealing with COVID. So we reward people by coming to meetings, by having a draw for a cheaper cell phone so they could stay connected, or tablets, And a lot of us were doing Zoom trainings, and showing people, here's how you do a Zoom, and here's how you mute and do all this. So, there's a lot of things changed. There was a lot of systemic change through COVID, and I hope that for the other pandemics, like TB has been around for hundreds of years, HIV is still here, and hepatitis C, we need to start learning the lessons. There was so much political will for systemic change for COVID. I think we need to start thinking about global pandemics that way, and there needs to be political will for systemic change. That's the only way we're going to get there.
Well, thank you, Trevor, and thank you, Nadia and Georgia. What a fascinating conversation. So to our listeners and viewers, I hope you have found this conversation useful. Don't forget to subscribe, give us 5 stars on your favorite podcast platform, and check us out on our YouTube channel. So with that, thank you very much indeed.
Hope you enjoyed this episode of the Vax Up podcast. If you'd like to learn more about the topics discussed in the show, please check the show notes or visit us on our website at www.vaxuppodcast.com. You can also find us on Facebook, YouTube, Instagram, and Twitter at Vax Up Podcast. And please consider subscribing to our podcast on Apple, Spotify, Google, or on your favorite podcast platform. The Vax Up podcast is produced by Hunuvat and NewsDoc Media. Writer and producer is Troy Espera. Graphic design by Michael Jarrett. Narration by Sherry CB, and the executive producers are Eric Aspera and Ben Plumley. Thank you, and see you next time.